Hi everyone, this is Dr. Garcia. We are about to do Chapter 10, the Healthcare System for Psych 4450, Community Psychology. Okay, when we talk about the American healthcare system, one of the things that we need to address is that Americans spend more on personal health care than most other countries, continents, and even regions. If you see here, this represents North America, which is inclusive of most of the United States. And as we continue to look at healthcare spending per head or per each individual person, Western European is about half, and then all these other countries, Central and Eastern Europe, Asia, Australia, Latin America, Middle East, and Africa regionally spend far less on healthcare than we do in the United States per person. Why is that? Because of social healthcare programs. So in most of these other countries and regions, there is social healthcare available. In other words, the government, the communities pay for healthcare services for the people that live within their countries and their communities. The United States, we do not have that social program set up for everyone to have access to healthcare in the way that other countries do. Most of our medical providers and healthcare providers are privatized providers, and although we have healthcare and insurance through Medicare, Medi-Cal, and other employment-based insurances, we still are paying a lot per individual on an annual basis across several years. If you look, these are numbers from 2018 with the projections to 2022 and how much we're paying these days. Okay, now, national health indicators are important, and the way that we understand how the United States is doing as far as its efforts to support healthcare is based on the World Health Organization. The World Health Organization looks at data and statistics across countries and continents, and so when it comes to those with the least neonate mortality deaths, in other words, infant deaths, we can see that Japan, Ireland, and Germany in the top 3, and the United States as number 10, behind Canada and Cuba, rounding out 8th and 9th place, if there's a place. When it comes to life expectancies, as you can see, the global life expectancy is 74 years of age. For females, however, the United States, it's 81. So comparatively, we're doing a little better than what's happening globally, but there are some countries that are doing far better, such as Japan at 86 years of age for females, and Canada and France, 84 and 85 years of age. Now, when it comes to global life expectancies for males, the United States is 77 years old for males, and again, globally it's 69. So men in the United States are living nearly a decade longer than what's going on globally, yet at the same time, we can still see there are other countries like Japan, again, and Canada that have far lengthier lifespans for males than in the United States. Okay, so let's talk about discrepancies of these health indices. The other thing that we know about the health indices when we look at the United States compared to other countries is that we have something called health disparities. In other words, is inequality that exists. Now, these inequalities within our healthcare systems in the United States happen because of one's ethnicity, where they live, whether they live in a rural or a city-based community, lifestyle, social class, meaning income, education, home ownership, and of course, whether or not someone has access to health care. So really, again, what we're talking about are health disparities. Specifically, health disparities are when there's statistical overrepresentation of a particular group compared to the rest of the general population. And so an example of this, when we look at, an example of what a health disparity is, cervical cancer in the United States has declined overall across the U.S. in most women. However, even though there's a sharp decline on cervical cancer overall, African American women have the highest rates still of cervical cancer, which is 39% higher than non-Latino white women. So this is where we see the disparities going on. Even though we should be dropping and declining overall, we see that one group has a sharp incline, especially comparatively, just under half of incidence rates of cervical cancer compared to white females. And so really, when we see these inequities or health disparities come to play, there's a lot of different reasons why. Language barriers, regional locations, like, again, rural communities, you have access to healthcare, cities. There are some beliefs, there's a heated debate. A lot of people debate as to why the health disparities exist. Some people say, well, you know what? Some cultural groups are just more susceptible to disease, such as Native Americans, are more susceptible, or American Indians are more susceptible to alcoholism and other substance use addictions. And then some people say, no, it's about cultural norms. In some cultures, the idea of seeking out sort of traditional westernized healthcare or seeing doctors is not typical to the culture. But others say, it really is to do with the minority status. And we don't just mean ethnic minority status. I mean a minority status such as your gender status, your economic status, your income status. You could be in the minority. And also, there's a lot of research in the world of psychology on race-based trauma. Race-based trauma is the idea and the notion that over time, the different isms such as racism, prejudice, discrimination has such an incredible impact on an individual's mental health and psyche, that it plays a role not only in their mental health trauma, but also how it influences their physical health as well. So there's a lot of debate and contention over why health disparities exist, but the reality is we know that it exists. It is there, and it's not just as one example of cervical cancer, but we can look at all these disparities in breast cancer for women. We can look at it in prostate cancers for men. We can look at the detail of the incidence rates and prevalence of infant mortality rates between different ethnic minority groups. So it is real, and it is a real problem in the United States. Health disparities, health inequity. So when we take a look at the healthcare system and kind of keep exploring, what's happening here, we have to understand that we've had in the United States, because we do not have governmental support, full governmental support, to like many of those other countries, as you noticed before in one of our first slides, that Americans are paying far more for healthcare per individual person compared to every single other country, region, and continent in the United States. We have to understand that how do we start financing healthcare anyways? In the 1960s, we started to have Medicare and Medi-Cal. Also, employment healthcare subsidies started to come into play with the recognition of needing to support individuals for healthcare. But, the interesting thing when it comes to employment healthcare, we haven't seen huge gains. In 2007, only about 15% of Americans had access to employment-based healthcare. Now, that did increase across about a 10-year span up to about 27%. But again, this is still really low. If we're staying about 27% of United States individuals who are working have employment benefits, that means 70% do not. So the good news is that we do have the Affordable Care Act from the federal government. Of course, there was a lot of political infighting, which delayed the process of the Affordable Care Act. It's gone through many shifts and transitions across the last couple of presidential support. And Congress has made a lot of shifts and changes to it. But nonetheless, since 2017, more than 20 million previously uninsured people have gained coverage. And this is very important because the Affordable Health Care Act, also known as Obamacare, who initiated this into Congress to try to pass this to sort of equalize this health disparity. That was the focus. Health disparity is real. Health inequity is real. Let's make sure that people have access and we can support individuals. So in spite of all the political infighting and the changing of its name and people not really understanding how it works and it becoming a political pawn, we do know nonetheless 20 million people who were previously uninsured have gained coverage. And that is a phenomenal feat in the United States. Now, a primary concern in the United States for healthcare is cost and access issues. Again, going back to health insurance, 70% of people do not have healthcare insurance in the United States. Therefore, they have to rely on things like Medicare and Medi-Cal, which can be very difficult systems to work with and work upon. There's also limitations of the type of services you can receive or specific treatment options that you can get. We also know that, doctor to patient fit is very important. And again, if you are on specialty programs that support you, Medicare and Medi-Cal, you're very limited to who you can see. Even healthcare providers, you could be playing in a lot as an employee to your healthcare services, but you don't always gain access to every provider you want. You still got to go off your list. And so doctor to patient fit is important. Understanding that there has to be trust between the patient and the consumer or the doctor himself is very important. Having cultural familiarity and having the same language and experiences as your doctor is also very important. Another issue that's of concern in the United States is adherence and compliance to treatment. We know that only about once a person finally does go to seek health services, we know that only about 50% are actually compliant. A little bit more than that are semi-compliant. In other words, they might start taking their antibiotics, but then they don't finish them. So a little more than 50% are semi-compliant and adhere to their doctor's requests, but most all, about half of the people in the United States are not compliant. And so a lot of internet interventions have been applied. A lot of health care companies do have like online portals. You can do telehealth. You can do, send messages to the nurse at your doctor's office and try to gain some support that way. We know that there's a lot of demographic variations and compliance measures as well, but some researchers, Di Matteo et al., did find that functional social support is what really helps for adherence and compliance to treatment. Again, adherence and compliance to treatment is when your doctor makes a recommendation and says, do this when you go home. How many people are actually doing that when they go home? Again, only about 50%. What increases compliance to treatment? Functional social support. Functional social support is just basically practical support from others. Practical support like getting, guidance, giving advisement, someone helping, right? If it means like, well, you need to change your diet and not eat so many foods with high, cholesterol levels or what have you. And so having family members who are conscientious of that and maybe prepping and planning foods around that person is what's really going to get that person to comply. So functional supports are much more important than structural supports. Structural supports are things like your income level, your education level, right? So that doesn't necessarily matter as much the people around you that are providing you care and concern. Let's see now. Let's move to the next slide. Here we go. Community psychology and the healthcare. So from this point forward, we're going to really look at sort of these community-based focused on healthcare. So let's start with prevention over remediation. The goal for most healthcare systems is really prevention. If we do prevention, there will be lower costs, less likely for people to not adhere or to become compliant, right? If we're doing prevention, then we don't have a lot more extensive chronic illnesses or chronic diseases that can become a part of our everyday lives. So a good example of prevention program is the Stanford program or the Stanford Project. At Stanford, what they did is they researched a heart disease prevention project, and really what they attempted to do was to do educational programming within targeted populations and communities. In fact, coastal cities in the state of California. And they did educational programming about heart disease, and they ran these campaigns in newspapers, on the radio, in TV ads, in print, like, those big signages and boards as you're driving up and down the coast and throughout the city. So coastal cities that had this educational programming that was, again, just done through newspapers, radio, and TV, they actually, all the folks that lived in those communities who received the education programming reduced their heart disease. So less people had heart disease, more people were paying attention to the needs to try to improve their health and their heart health, and also reduce the number of deaths or mortality relating to heart disease. So they felt that this was really important, and they started to engage in the communities and really devise interventions and really talk to community members to think about what else can we do. If this is working, what else can we do? So they elaborated into, in community engagement, looking at prolonged interventions, and in the end, they came out with community level health outcomes. It wasn't just individual outcomes when they start to sort of fold in community members to have these conversations about, what are good interventions that will help you to be compliant and adherent as well as to be preventive. Community level health outcomes just skyrocketed to be beneficial. So really healthcare has certainly shifted from individuals to the group, and that's what community psychology is concerned about. Not just doctors, although they may be practicing and giving care to one single individual. We know that the bigger picture in healthcare systems is attempting to sort of target neighborhoods and communities. Really have to really look at what the communities are around them, define those communities, and find people in the communities that will be agents of change, such as community psychologists, right? So once you have people in place that are active advocates for community change, like psychologists, and really become agents of change for not just an individual, but for a whole collective group of targeted individuals in a community, we start to see an increase in better health outcomes as well. So community cohesion is important for this to work well. Friendships, participation, how involved and engaged you are with other people will make a difference. And again, that's important for having good health outcomes or health indicators, the sense of community cohesion. When you have community cohesion, medical researchers and medical prevention programs can then target better to neighborhoods and communities, special health education programs, finding individuals who are supportive of that within the community as agents of change, and we start to see much better health indicators. Fit and risk is also important, like goodness of fit is linked to health outcomes. When we say goodness of fit or fit is really about like similarities between the individual and their social environment, the individual and their access to environmental resources, right? And so how the individual and these environmental resources coordinate together. If you have a goodness of fit within your community, you will have a much better well-being, both with your mental health and your physical health. Unfortunately, there are risk factors, right? So if you live in a community and you have a limited fit with your community, there are risky behaviors like social disruption. So if your community has more violence and more things that people have to worry about, and exposure to trauma, this is not going to be a good fit, and it's not going to be a healthy outcome as well. So we really want other communities that are at risk are those that people that have no sense of community. That's what's kind of behind me in this video right now. No sense of community, no sense of religiosity, and even no maternal warmth can also be risk factors for poor well-being and concerns for physical health. So generally, systems have to think about how they're going to be inclusive for all members and making sure that all have access to good healthcare programs and systems. So even though, you might have a hospital setting or one setting, you need to have a lot of services that rotate around the community. So really it's important to build systems of healthcare. I have a family member who's a doctor, and I said, the healthcare system's really fractured. And her response was, what system? What healthcare system? In other words, we don't really have a strong system in place. The foundation of healthcare and medical care in the United States wasn't founded on providing healthcare services to all members. Really, medical approaches and medical schools were providing healthcare supports to those who were the elite in the United States hundreds of years ago, to those who were wealthy. It was never really built on a system to equalize access to healthy programs and resources for all. So it's never really been built on a system. It's actually been built on an institution of elitism, and those with wealth and affluence could gain access. So building systems and collaborative systems within community is incredibly important, right? So and collaboration brings out changes, and there's certain synergy and energy when people connect, and increasing accessibility is important as well, making sure people have timely interventions, that you're not just waiting until you're extremely sick with many chronic illnesses, that you're getting the interventions that you need, having systems do education, things like helping people to make lifestyle changes, like wearing a seatbelt is going to save your life than if you don't wear a seatbelt. Health literacy, and really making sure that people have periodic timely interfaces with their medical provider, right? So making sure that they're going to their checkups, getting their vaccinations, etc. Combining resources to build systems, primary care doctors, specialists, mental health service providers, case management, nursing support, that's just to name a few that really should be combined together and housed in one space. What I'm really talking about is something called integrated care. Integrated care models really, again, are these houses all services under the same roof, really making, access to professionals possible for individuals. A good example of that has not had good integrated care is like your primary care, also having mental health and substance abuse care in the same space. They're not often part of our primary care facilities. So an integrated model where all these services are housed under the same roof, you get easier access to referral, coordination of services amongst different professionals, better communication, higher adherence rates, right, to treatment interventions, right, and actually convenient model of healthcare. Right now, the healthcare system is an inconvenient system. It takes a lot to get your referrals, to see a doctor, to get the treatment you need, and the individual is coordinating their care. And if you don't have the stamina, the time, the resources to really coordinate your own care, things can fall through the cracks and things can drop. This is so important, incredibly important, particularly for diverse communities. So in diverse communities, we know that integrative care is very important. We need to be doing community outreach with good, public health education as well. Doctors and professionals, whether it's case managers, mental health supporters, primary care physicians, we should make sure that we have people who speak the language of those who are coming to see us. Biculturalism is important as well, making sure that doctors and other care providers understand the different cultural values as it relates to medicine, medication, alternative approaches, cultural normed approaches as well, and really using community settings. A person should not have to drive 40 miles away to go get specialized services. They really should be able to get access to good health care within their community settings. And the Access Plan is an example of a program where that uses community-based organizations to sort of insulate an individual with all different types of services so that they can gain better access to community health care. Things like, just walking somewhere like, I need to get to my doctor. Here's a transportation voucher. I need to, my mother's having a special surgical appointment and I really want to be close to her because she has to go up to the hospital. Here's a housing voucher to spend 3 days at the hotel next to, the hospital. These are very important, accessibility type offers that people in community do need to support healthcare for themselves and others. Rural health is another important area because we know that some people live in rural settings and they don't have access to health care. This is another health disparity or inequity issue. Rural settings, for instance, it's important to engage communities in devising special programs. A lot of these rural health programs that are really trying to be more strength focused and provide developing resources that are unique to individuals within these rural populations. There's one program in North Dakota, where there's a lot of Native American communities, and so meetings were held to define sort of the healthcare needs, the healthcare barriers and challenges, and how the rural sort of health center could help individuals gain access. Hawaii is another one. Hawaiian community members, really defined the goals for healthcare in their communities. What strategies and objectives and action plans are needed for healthcare programs? They identified in the Hawaii program multi-level problems such as, lack of leadership, lack of healthcare services, high rates of drug use, and even lack of access to services as well. Finally, social support and healthcare. So again, social support is incredibly important. A meta-analysis of the research tells us that social support has a positive impact on specific health areas, behavioral and psychological impact, right? When you have good social support networks, your behavioral health and your psychological health can improve, and psychological and physiological pathways are interconnected together. If you have this mind-body interconnection, psychological, physiological, but if you have good social supports, then you can have a well-balanced both psyche and physical health. Thanks for watching, everyone.